Okay, today we will discuss about the questions, the clinical and pharmacological characteristics of the antihistamines drugs, pharmaceutical care for the treatments of allergies. Lecture outline, that is the clinical indications of the antihistamines, rhinitis, urticaria, the clinical symptoms of allergic reactions of the organism, the histamine H1 receptors, first generation, second generations, speed of onset of the actions, anti-inflammatory effect, eliminations, another pharmacokinetics indexes of these drugs, unwanted effects, somnolence, cardiotoxicity, and another problems. Now, for the first, the clinical indications of the antihistamines drugs. Antihistamines have a number of the clinical indications, including the allergic conditions, rhinitis, dermatitis, atopic dermatitis, contact dermatitis, allergic conjunctivitis, hypersensitivity reactions to drugs, mild transfusion reactions and urticaria, chronic idiopathic urticaria, motion sickness, vertigo, and insomnia. In allergic conditions, histamine and other substances are secreted from the mast cells, basophils, and other cells type. Histamine then binds to the activates specific receptors causing smooth muscles constriction, vasodilatations, endothelial permeability, and sensory nerve stimulation. These actions of the histamine manifest clinically as a characteristic allergic sign of the symptoms: sneezing, rhinitis, rhinorrhea, erythema, pruritus, and urticaria. Oral antihistamines generally provide relief of these symptoms, which are all associated with the early response to histamine. Symptoms of nasal obstructions are characteristic of the late allergic reactions and they're minimally relieved by antihistamines. No, that is the classic clinical symptoms, pollinosis, that is the conjunctivitis. Usually that is the combinations of the conjunctivitis plus rhinitis, when the patient has the allergic reactions to the pollutant, to the plants, usually in summer. But some patients think, and will talk you, I don't want to use these any anti-allergic drugs because it is the chemical drugs, it is the problems for my liver, for my practically kidneys and other internal organs. Maybe that is the not serious problems. But you must understand these combinations, conjunctivitis and rhinitis, has named their pollinosis, provide later in these patients without the treatment the progressions of the symptoms of the bronchial asthma. That is the serious argument for the prescriptions of the anti-allergic, antihistaminic drugs for these patients. And if you have any clinical symptoms of the chronic allergic irritations, eyes and nose, please use antihistaminic drugs because that is not very toxic drugs in real clinical practice for the organism. But the preventions of the progressions this disease to the asthma, that is the serious questions for health of our patient. It is there, for example, the urticaria, that is the dermatitis, and patient sometimes has the contact dermatitis. Symptoms of the rhinitis, that is referred to the disease involving inflammations of the nasal membranes. Symptoms include nasal discharge, sneezing, and congestion. Rhinitis is inconsiderate pathological when symptoms are severe enough that require therapy. Rhinitis may be infections or non-infections irritation. Non-infections or allergic rhinitis, may be as seasonal, seasonal allergic rhinitis, another name that is the pollinosis, perennial allergic rhinitis, and is characterized by nasal mucous membrane swelling and the blockage, reflex sneezing, and the hypersecretions and ocular manifestations, including itching, turning, and the conjunctival edema and the redness. Non-allergic vasomotor irritant rhinitis, it also common and responds better to topical nasal steroids than oral antihistamines, although moderate response can often be seen with the topical nasal antihistamines drugs. Rhinitis, classic clinical symptoms, irritations, catarrhal symptoms, itching, and others. Urticaria or hives is a condition characterized by transient prurity quills, swellings that are primarily the results of the histamine release from the mast cells. It is estimated that at least 50% of the general populations have experienced urticaria at one time or another. Chronic urticaria is usually defined as a recurring episodes of urticaria lasting 6 weeks or more. The etiology of chronic urticaria can be physical stimuli or may be idiopathic. Types of the chronic urticaria that occur in response to the physical stimuli include dermatographism, urticaria in response to the stroking, frictions, or rubbing. Cholinergic urticaria, where the stimuli that raise the core temperature of the body elicit urticaria. Cold urticaria, where wills occur after exposure to cold. These conditions is rarely associated with underlying disease. Solar urticaria, provoked by ultraviolet light, and aquagenic urticaria, precipitated by contacts of the skin with the water of any temperature. So-called idiopathic urticaria may be due to the autoimmune process, maybe in 40 to 50% of all patients. Classic clinical symptoms, serious problems for our patients. Usually the patients cannot feel long time the itching. Practically all symptoms of itching, the patients transform to the pain because it is a serious clinical symptoms for our patients. The classifications of the antihistamines. Antihistamines are classified in the first generation sedations, including the chlorpheniramine, diphenylhydramine, promethazine, and hydrazine, and never. The newer antihistamines are sometimes referred to as second generations, relatively non-sedations, including the terfenadine, astimazole, loratadine, cetirizine, and levocetirizine, and third generations, including the fexofenadine, norastimazole, and this carboxyoxyloratadine. First generation antihistamines are highly lipophilic and therefore readily cross the blood-brain barrier. Contributions to adverse central nervous system's effect, including sedation, drowsiness, and decreased cognitive processing. First generation drugs also have relatively short half-lives, necessitating multiple daily doses. For example, the chlorampheniramine maleate, that is the first generations of the antihistamine drugs, with very many side effects. Diphenylhydramine hydrochloride, 25 mg per tablets. Terfenadine tablets. Sometimes these drugs provide the cardiotoxic effect for our patients, increasing the size of the QT. Loratadine, that is the modern second generations of the drugs, and our patients like to use these drugs. Only 1 tablet per day, and long time. Sometimes the allergic patients use these drugs with the serious side effects after the using 10 milligrams and 1 tablets. Cetirizine, very popular drugs. Cetirizine hydrochloride, antihistaminic drugs, only 1 tablet per day, 10 milligrams. We saw the indications for using of these drugs: sneezing, runny nose, itchy, watery eyes, itchy throat and nose. Levocetirizine, that is the newest generations. Levocetirizine hydrochloride, 5 milligram, antihistaminic effect, only 1 tablet per day, with the very good, excellent results of treatments of these patients. And you must repeat, please, if your patients don't use with the symptoms of the irritations of the eyes and nose, without the temperature, without the clinical symptoms, bacterial or viral infections, classic allergic reactions, proposed for these patients. These patients must go maybe to the allergologist, for example, family doctors, for the prescriptions of the antihistaminic treatments for the stopping of these serious systematic allergic problems. Okay, the original second-generation agents were terdenafine or astimizole. Both were removed from the market after the case report of the prolonged Q10 interval resulting in torsade points. Both of these drugs exhibit potassium plus blocking properties in cardiac conduction tissues and had cytochrome oxidase P450, CIP, isoenzymes CIP3A4 dependent metabolism. Case report of these use of the terdenafine with the concomitant ketoconazole were the first link between altered drugs metabolism and adverse events. We remember in your questions of the CROC2 and the government examination questions, we can find very many questions about the biotransformations drugs. We understand these antihistaminic drugs, that is a substrate of the CIP3A4, ketoconazole, and all another antifungal drugs, and metronidazole, and erythromycin, and clarithromycin, and grapefruit juice has the very intensive inhibition effect to the CIP3A4, and CIP3A4 cannot destroy it of the substrate of these isoenzymes, and concentrations of the isoenzymes, for example, the antihistaminic drugs, will be increased and provide another absolutely dangerous side effects. But these situations we can induce if you will add to our treatments of the allergic patients the inhibitors of the CIP3A4. Please remember metronidazole, ketoconazole, intraconazole, all antifungal drugs, erythromycin, clarithromycin, grapefruit juice. These drugs induce the very intensive increase in very many drugs, the substrate of the CIP3A4. While the QT prolonging properties of astemazole were not as well defined, its long half-time of the 48 hours up to the 12 days for its metabolite. And the presence of active metabolites presented a potential risk for the adverse events. The histamine H1 receptors, the human histamine H1 receptors is a member of the superfamily of the G protein coupled receptors. These superfamily represent at least the 500 individual membrane proteins that share or a common structural motif of the 7 transmembrane helical segments. The histamine H1 receptors genes encode of the 187 amino acid proteins with a molecular mass of the 51.8 kilodalton. The absence of introns in the H1 receptors gene indicates that only a single receptor's protein is transcribed with the no-splice variants. That is the structure of the histamine receptors which provide the, for example, allergic reactions or anti-allergic reactions if you will block these receptors after the using of the antihistamine drugs. The histamine H1 receptors, like other G proteins coupled receptors, may be viewed as the cellular switches, which exist as an equilibrium between the inactive or off state and the active or on state. In the case of the histamine H1 receptors, histamine cross-links sites on transmembrane domains 3 or 5 to stabilize the receptors in its active conformations, that thus causing the equilibrium to swing to the on position. H1 antihistamines, which are not structurally related to the histamine, don't antagonize the binding of histamine but bind the different sites on the receptors to the produce of the opposite effect. For example, cetirizine cross-link sites on transmembrane domain 4 and 6 to stabilize the receptors in the inactive state and swing the equilibrium to the off position. Because first generation H1 antihistamine derived from the same chemical stem from the which cholinergic muscarinic antagonist, tranquilizers, antipsychotics, and antihypertensive agents were also developed, they have the poor receptor selectivity and often interact with receptors of other biological active amines, causing the antimuscarinic, anti-alpha adrenergic, and anti-serotonic effects. But perhaps their greatest drawback is the ability to cross of the blood-brain barrier and interfere with histaminergic transmission. Histamine is an important neuromediator in the human brain, which contains approximately 64,000 histamine production neurons located in the tuberomammillary nucleus. When activated, these neurons stimulate H1 receptors in all of the major parts of the cerebrum, cerebellum, posterior pituitary, and spinal cord, where they increase arousal in the circadian sleep-wake cycle, reinforce learning and memory, and have roles in fluid balance, suppressions of feeding, control of body temperature, control of the cardiovascular systems, and mediations of the stress triggers, release of the adrenocorticotropic hormone and endothelin from the pituitary gland. It is not surprising that the antihistamine is crossing the blood-brain barrier there, interfere with all of this process. Physiologically, the release of the histamine during the day causes arousal, whereas the decreased productions at night results in the passive reductions of the arousal response. When taken during the day, first generation H1 antihistamines, event of the manufacturer's recommended dose, frequently causes daytime somnolence, sedations, drowsiness, fatigue, and impair the concentrations and memory. When taken at night, first generation H1 antihistamines increase and latency to the onset of the rapid eye movement sleep and reduce the durations of rapid eye movement sleep. The residual effect of the poor sleep, including impairment of attentions, vigilance, working memory, and sensory motor performance, are still present the next morning. The detrimental central nervous system's effect of the first generation H1 antihistamines on learning and examinations performance in children and the impairment of the ability of adults to work, drive, and fly aircraft have been reviewed in detail in the recent review. The use of first-generation H1 antihistamines in young children has recently been brought into question. In US, reports of the serious and often life-threatening adverse events of promethazine in children led a boxed warning being added to the labeling of the promethazine. The warning included the contraindications for use in children younger than 2 years and a strengthened warning with regard to use in children 2 years of age or older. Second generation of the H1 antihistamines. When choosing an H1 antihistamines, patients seek attributes that include good efficacy, rapid ones of actions, long durations of actions, and freedom from unwanted effects. Although some of these attributes may be predicted from the preclinical and pharmacokinetic studies, it is only in the clinical environment that they may be definitely established. The efficacy of the H1 antihistamines is determined by the two factors: the affinity of the drugs for the H1 receptors, absolute potency, and the concentrations of the drugs at the sites of the H1 receptors. Many factors affect concentrations of free drugs in this compartment. First, it must be absorbed into the systematic circulations after the oral dosage or with the tablets of the capsule. Most H1 antihistamines are well absorbed, the exception being fexonidine, foxafenadine, which has a very variable absorptions because of the influence of active transporting proteins is described later. Second is this extent of the plasma binding which with the H1 antihistamines is high, wherein the from the 65% with the disloratadine to 90% of levocetirizine. Third, and probably most influential, is the apparent volume of the distributions, which determines the plasma concentrations of the drugs after the completed body distributions. The apparent volume of the distributions is limited of levocetirizine, only the 0.4 liters on kilogram, larger for the fexafenadine, 5.4 to the 5.8 liter to kilogram, and particularly light from the disloratadine, more than 49 liters per kilogram. That is the drugs from this group: disloratadine tablets, levocetirizine tablets, 5 milligram. The calculations to receptors or occupancy after single oral dose of drugs show values of the 95%, 90%, and 75% for fexafenadine, levocetirizine, and disloratadine, respectively, indications that they are all very effective H1 antihistamines. Although receptors occupancy for these drugs appears to correlate with the pharmacodynamic activity in skin wheal and flare studies and with efficacy of the allergen challenge Chambel studies, are the difference relevant in clinical practice. Studies in allergic rhinitis suggest that the above three drugs are of the similar effectiveness. However, in chronic urticaria, in which local histamine concentrations are high, the differences seem to be important. For example, in head-to-head studies in these conditions, levocetirizine appears significantly more effective than disloratadine. Fexafenadine, hydrochloride tablets, 180 milligram. Sneezing, runny nose, itchy, watery eyes, itchy nose and throat, direct indications for using, if that is the allergic etiology factors. The speed of onset of the actions of the drugs is often equated to the rate of its oral absorptions. The inhibitions of these histamine-induced flare response, indicative of the preventions by levocetirizine or of sensory neuron stimulations in the extravascular space, plotted against the concentrations of free drug in the plasma. In the study of children, plasma concentrations of drugs are near maximum by 30 minutes, and yet it takes an additional 1.5 hours for the drugs to diffuse into the extravascular space to produce a maximal clinical effect. In adults, the maximal inhibitions of the flare response is usually 4 hours for the levocetirizine, fexafenadine, and disloratadine, but may be longer for drugs such as loratadine and embastine, which require metabolism to produce the active moiety. Anti-inflammatory effect. Although the majority of the research into the H1 antihistamine has focused on the histamine-dependent early phase symptoms of the allergic response, it is now becoming clear that the drugs have anti-inflammatory effect. This follows the observations by Baker and the colleague that histamine can activate NFKB, a transcription factors involved in the synthesis of the many pro-inflammatory cytokine and adhesion molecules involved in the initiations and maintenance of allergic inflammation. Elimination. The metabolism and eliminations of the H1 antihistamines have been extensively reviewed. Elsewhere, they will be only briefly summarized here. Cetirizine and levocetirizine are not metabolized and are excreted primarily unchanged in the urine. Disloratadine, undangerous extensive metabolism in the liver. Although this gives the potentials for drug-drug interactions, no significant interactions have been reported. Fexofenadine, which is also minimally metabolized, is excreted primarily in the feces after it active secretions into the intestine under the influence of active drugs transporter molecules. This gives the potentials for the interactions which agents such as a grapefruit juice and St. John's Wort, which inhibits their transporter. Although plasma concentrations of the fexofenadine may be increased by the agents, no significant resulting adverse reactions have been reported. Somnolence, one of the unwanted effects. A major reason for the reduced penetrations of the second generation antihistamines into the brain is because their translocations across the blood-brain barrier is under the control of the active transporter proteins, of which as the ATP-dependent efflux pump, P-glycoproteins, is the best known. It also became apparent that antihistamines differ in their substrate specificity for the P-glycoprotein, fexofenadine being and the particularly good substrate. In the brain, the H1 receptors occupancy of fexofenadine aside using positron emission tomography scanning is the negligible, maybe less than 0.1%, and in psychomotor test, fexofenadine is not significantly different from placebo. Furthermore, fexofenadine has been shown to be devoid of central nervous effects event at supraclinical dose up to 360 milligrams. Cardiotoxicity. The propensity of estimazole and terfenadine, the block of current pump, they prolong the QT interval and to potentially cause serious polymorphic ventricular arrhythmias, such as a torsade at points as well documented. These two drugs are not longer approved by regulatory agencies in most countries. In addition, some first-generation H1 antihistamines, such as the promethazine, brompheniramine, and diphenylhydramine, may also be associated with the prolonged QT and cardiac arrhythmias when taken in the large dose of the overdose. No clinically significant cardiac effect have been reported for the second-generation H1 antihistamines loratadine, fexofenadine, mesalazine, ebastine, azelastine, cetirizine, disloratadine, and levocetirizine. For example, that is the estimazole, 10 milligram in 1 tablets. These drugs sometimes can induce the QT increase in the size of this part of the ACG and provocate the pro-arrhythmic effect. Terfenadine, antihistamine drugs, and these drugs sometimes provided some problems for heart of our patients, especially together with the combinations with the inhibitors of the CYP3A4 and inhibitors of the P-glycoprotein. Thank you for your attention.